Hi, I'm Dr. John Ventura with the Primary Spine Provider Network and Spine Care Partners. And this is our Primary Spine Provider Network webinar series. And today we're fortunate enough to have one of my partners in those companies, Dr. Tom Neuner, who is also a JD degree. He has his law degree also, and has a medical law practice in addition to his work with Primary Spine Provider Network and Spine Care Partners. And he practiced chiropractic for 37 years in the state of Michigan. And we're going to have him tell us a little bit about that. And he is one of the founding partners of Spine Care Partners and Primary Spine Provider Network. So I won't go too much detail since we're going to be talking about your background, Tom, and how it led you to where you are today. So welcome, Tom.
Yeah, thanks, John. Thanks for that introduction. And just doing a quick sound check. Can you guys hear me okay?
Yeah, it sounds good.
All right, good.
Yeah.
Yeah, this is quite the opportunity. I really look forward to speaking in front of this group. You know, I did start, it's been about 40 years ago, graduated from chiro school, and what's that, 1984 to now? Boy, a lot happens in 40 years. I mean, think about it. If you look back at sliced bread, I think that was invented like in 1918, maybe 1920. Sliced bread. And sliced bread, by the way, was outlawed for a few months during the war effort. But sliced bread, invented in 1920, and to 1984 when I graduated, that's, you know, maybe 60 something years. And so 1984 to now is 40 years. A lot happens in 40 years. Unbelievable.
Yeah.
So a lot's happened in my life. And without boring everybody about that, you know, just to talk a little bit about college real quick. I did go to National. That's where Dr. Jancy was. I don't know how many people realize who he is or who he was. He was still active at our school. And, you know, going through school, I was there with John. I was there with a couple other partners and Spine Care Partners. And we had classes like, you know, for one thing, you're going through anatomy, which is right in your face. We had one of the strongest anatomy programs. It's very structured, very evidence-based, as it were. And you'd walk from that class to acupuncture, where I was having a hard time trying to figure out, you know, where this information comes from. How's it supported? I know it's standing on 5,000 years of usage, but, you know, I couldn't understand the cause and effect and the evidence behind it. And I think that was like the first time I really started to question, like, what the heck is going on in healthcare, you know? But more on that later. I did do a rotation down in downtown Chicago. John, where did you do your rotation?
I was right on the main campus in Lombard.
Alrighty. And the thing about downtown Chicago is they had us do see pretty much every type of disease state you can imagine out there.
Yeah.
We were seeing in downtown Chicago clinic. I mean, we had to do like a good number of pelvic exams before they would let you out of there. And I'm thinking to myself at that time, as I'm doing a pelvic exam, when I find these problems with a person and a patient, what tools do I have to remedy this? What solution do I have, you know, at hand? And obviously it's not the manipulation, subluxation, but what is it? And a lot of those really weren't answered for me. You know, getting out of school, I did come out of school in 84. I start going into practice, and instantly back here in Michigan, I feel like I'm on an island. So I'm practicing. I started practice with another clinician. Get this, his practice was probably 10 years old at that time, maybe 5 years old. And my note taking was done on what's called a travel card. And we wrote our notes, I'm not kidding, in a 1 inch by 1 inch square.
Yeah.
And David, that's really got to knock you off your socks. That's the state.
Your entire self note.
Yeah, that was it. That was the state of practice in Michigan. And I couldn't figure out, you know, why I'm on an island. And I would look at that and I look at my medical counterparts and those around me. Nobody's talking, you know, they refer back and forth a little bit, but, you know, there's no such thing as co-management, anything like that. So I really pursued that. I tried to talk to these clinicians and say, hey, what about your spine patients? What are you doing with them? I just send them over to the neurosurgeon. And pretty much every PCP says, when they send a patient to a neurosurgeon, they'll say these words: all right, Miss McGillicuddy, I know you have this trouble. We haven't been effective, but I'm going to send you to the best neurosurgeon in Michigan. It's never the second best, right? It's always the best neurosurgeon. And what they get out of that, they get this feeling like they're giving the patient this high value. Boy, my doctor knows the best neurosurgeon, so on and so forth. So in that, there's all kinds of these little pearls and messages of cultural authority, low value care, what's good for the patient, cost. I mean, all of that is I'm experiencing at that time, but I didn't really realize it for what it was. So it took a long time for me to get people not only to refer to me, but to actually come in and practice in my office. So as I was going through practice, I befriended a neurosurgeon that I would go down to the theater and watch him operate. One time he was operating a patient, and he says, "Here, hold this." And it was I believe the tool is called a wrangler or something, but you're looking over the patient, and there's this team of people around him, and everybody kind of looks at each other over their masks, like, "Uh-oh, here comes the lawsuits." And that's where I started thinking of this cross-pollination of liability between us, which is called vicarious liability, which I'd like to talk about later, John, if you allow me to.
Okay, you bet. We'll bring it up.
Yeah, and as I'm going through that, this surgeon, we just had such a good time with our patients, back and forth. I would see people before he would operate. Some would make it past me to him. Many would not, as you can imagine. But then he says, "Tom, I want to sponsor you in school," which means he wanted to pay my way through medical school and then on to neurosurgical rounds, which was really an unbelievable opportunity. I did not take it because I would have had to move my family out of my home, which I was born in, and I still live in to this day. And it just wasn't my bag. I just like the idea of chiro. So anyways, I still went forward and kept moving along. And I did have quite a good career with a lot of medical people in my office. I did practice 11 years as the only chiro at Michigan Head and Spine Institute, which is made up of 17 neurosurgeons, a handful of physical therapists, a lot of PM&R docs, and one chiro. I did add another chiro at about year 9. That's a little bit different story. But throughout that time, John, where the law came in is I knew that I did hurt myself twice within a 6-month period. And that takes you out of practice. And as everybody knows, when you're delivering physical medicine, if you can't do that, you're done, right? Nobody's going to pay the bills for you. So I got a little scared, and yet I still was trying to figure out this barrier between, professional relations. So I knew it was law-based because I could see that of why people did not refer. I knew it was referral loops. I knew it was the way systems pay. And I said, okay, this is where I think a legal degree, a law degree will come in handy. So I went to law school, and that served 2 purposes. It gave me that outlet, helped me blend the professions together. It helped protect me from injury if I'm ever injured. And so, onward and upward. And as Dave says, Bob's your uncle. So that's kind of like my practice in a nutshell.
Yeah. I do want to say to the group, if you do have a question, please, and you want to just type it in the chat function on the bottom toolbar. You have a chat function. If you would like to speak and ask your question or make a statement, just raise your hand, and our webinar host, David Payton, will acknowledge that you'd like to ask a question, and we'll unmute your computer. Yeah, great, Tom. That's fascinating. So, I know a question that comes up when after hearing, of your practice and building into a multi-profession group practice, and then your opportunity to work with that neurosurgeon. The simple answer is, how did you get those opportunities? And I know how you did. You asked. But can you expound on that a little bit? Did you initiate the conversation with these other providers, like with MHSI or with that neurosurgeon who you started with? You just reach out to them?
Right,
Do you have a mutual
right. Yeah, and
patient with them?
yeah. I'm not muted, am I? Let's see here.
No.
No, I'm good. Yeah, that was a long journey also. There's things that clinicians can do. One thing as a clinician, you have a lot of risk exposure. And as an attorney, I really do start to look at that. But I also realized that risk exposure, my son Clint said it best. I think he kind of stole this from somebody else, but the bottom line is, he said, Daddy, all the fruit's out on a limb, and to get to the fruit, you got to take
Yeah,
some risk. I mean, doesn't that make
yeah.
sense? And so risk exposure,
That's a
you can
great
turn that
line.
into opportunity.
Yeah.
And that's how I did it. I looked at what was risky for me as an attorney, and then I turned that into opportunity. And what that means is going out there and talking to these clinicians. There's a whole litany of things you want to do when you look at building your practice and trying to get these relationships. And one of the single biggest things is to identify the other clinician's needs and then hold your solution out as an answer to those needs. So that's how I did it. I literally went to this large neurosurgical group, MHSI, and this was after I've had a multitude of PCP referrals and so on and so forth. I went to the neurosurgical group, and I said, wouldn't it be great to have that front end of spine? It'd be another portal for not only patient intake, but it allows us to treat people to make sure that they need surgery. And a lot of that was off base, John, I really have to tell you, but that was the spiel that I gave them. I think when you distill it down, you're showing that clinician that you're predictable. Here's what you do for spine. Here's how I'm going to help you. I think that's the biggest things.
Yeah, you're building trust.
Mm-hmm.
And that's a step-by-step process. That doesn't happen overnight. You have to build trust over time.
Right.
Yeah.
Right.
And great. There's a new term, a CIN. There's so many acronyms out there nowadays. There's MSO, which is Management Services Organization. There is ACO, Accountable Care Organization. There's PHO, Physician Hospital Organization, and a multitude of iterations of those terms. But one that really caught my attention is CIN, a clinically integrated network of providers. And it's been my impression that a lot of people confuse collaboration with integration, right? That they say, well, yes, I'm working in an integrated model of care, but technically all it really is a collaborative model of care, right? You're working alongside. It's like parallel play that Piaget talked about when you put 2-3-year-olds in a sandbox together and it looks like they're playing together, but they're not. They're doing parallel play. I'm doing what I do and you do what you do, but we're doing it next to each other. And I think that's most models of multidisciplinary care. They just work alongside each other. But unless you implement specific strategies to move towards integration, it just remains collaborative. So I know what you were doing actually moved more towards integration, your model of practice. And now in advising people through PSPN and Spine Care Partners as a medical legal attorney, for our company, I know you've had to weigh in on the whole model of integration. And if you do have an integrated model, where are the potential pitfalls like vicarious liability and such? So tell me your take on long way to get to this question. Give me your take on the distinction between a collaborative model and a truly integrated model.
Yeah, and John, that's an excellent question because again, you can talk about that. I mean, literally for months. But I'll talk about the experiential side of it first from my viewpoint. Okay. So we always talk about, oh, let's have this integrated practice. Great. Let's bring people in and do all this wonderful stuff for a patient. So what happens is I integrated, neurosurgery and pain management, physical therapy, massage therapy, acupuncture um, into my office. So we're integrated, right? You have everybody in this brick and mortar, and you're treating patients. You're interacting. I call this one hallway we would all walk through, kind of like the bat cave, where you can see the other clinicians. And I talked to one of the neurosurgeons that's implanting a device in my office in a patient's spine. Did you try this, that, or the other thing? It falls on deaf ears. Or PM&R doc who's saying, yeah, maybe your patient Tom needs some of this XYZ. And I'm like, no, that's kind of like the wrong thing to put up there in front. So, we would mix a little bit like oil and water, but even the collaboration part, John, the only part you're collaborating on is a brick and mortar.
Yeah.
But the cooperation that's needed to give a patient what she needs at a specific time in a timely fashion throughout this episode of whatever that back pain is. And there's all different grades, right? Hence the treatment pathways. That was absolutely lacking. In fact, it was actually influenced a lot, by the Tower of Babel. And that's my best example to give that is like,
you're going to have
I
to
say,
explain that one to me.
I will.
How you got to that.
Yeah, we're familiar with the Tower of Babel, right? I'd be in a back hallway, and if you say a word like CA to a chiropractor, they probably think chiropractic assistant. If you say it, to a medical clinician, they're going to think cancer. If you say it to the patient, they're thinking California. Well, I mean, that's pretty obvious. But think of something like when you say joint instability, that's entirely different for a surgeon compared to a chiro, and even compared to a physical therapist. So this Tower of Babel gets in the way with cooperation and true, collaboration between your clinicians. And as you know from our work, John, we talk about pathway-based care, and pathways fit in perfect into community-based care, which is there's certain elements you have to satisfy for a good pathway. And John, recite those for me real quick, if you would.
Yeah,
There's
have to
shared
have
decision making. There's
standardized classification. You have to have tools to coordinate care. You need tools, and to coordinate care means just what you had said: right patient to the right provider at the right time. And you need, and the pathway gives you some of that. The algorithms. And you need standardized classification, tools to coordinate. You need tools to enhance communication. And I know you have a lot to say on the idea of a standard electronic health record is a way to enhance communication. But enhanced communication can be as simple as using, Post-it notes, different colored Post-it notes that everybody can see and have access to. You focus on the first touch, right? Which is another thing you've always promoted, which is the early contact providers who sees the patient first can make all the difference between a successful and a bad outcome. And then you need, support in some way or another, whether it's from staff or whether it's from administrators or whatever.
Exactly. And now we come to the punchline, the reason why you form these groups that we're talking about, CINs, is to deliver exactly what you said. It's impossible to do it on your own, standing as an island. So what we've seen nationally is a trend, and in fact, an evolution of forming groups. And a group can be first an independent physician group. We've seen those. We've seen physician organizations. We've seen physician hospital organizations. We've seen accountable care organizations. We've seen management services organizations. And why all the different names? Because all the name is, I'm naming a group, and that implies what type of structure that you have to be able to deliver the things that you just said to your clinicians. And just as importantly, the group name is going to be a little bit different depending on the contracts that you're trying to service and the laws and the regulations within your state. So a clinically integrated network has specific things that it has to satisfy regarding not only community-based health efforts and help managing providers to deliver what you just said, but also in satisfaction of certain efforts that come down from the feds. And that is, for instance, in a clinically integrated network, that bypasses some things that we know here on this meeting, right? Like the Stark Law, and like unfair practices of organizing clinicians, clinician unions, things of that nature, practicing as an insurance company. So all of these things, a clinically integrated network is one of the, I don't want to call it a loophole, but it's one of the exceptions that the federal government will give you in order to deliver the things that you want to deliver. And so that's probably the shortest answer I can give you. It also allows to give you, some care quality initiatives that you just cannot roll out unless you have those things that you said as delivered through this clinically integrated network. So that's the difference. Clinically integrated networks are going to help you clinically. Management services organizations help you with practice management.
Can a clinically integrated network negotiate on behalf of providers? Because, I know there are a lot of antitrust laws that prevent providers from doing group contracting, what you were mentioning.
The short answer is yes and no, Johnny.
Oh,
it's really the short answer.
Now,
and the reason is because
answer, Tom.
Well, you know why? It's going to be different depending on the region you're in. So if we have a bunch of different people from different states, it may be yes, and maybe no. Think of it this way, like an MSO, think of that like one great big giant bubble with a lot of things going on in it. Within an MSO, you can have a clinically integrated network over here. You can have a high performing network over here. You can have just a management services agreement over here, so on and so forth. So this big corporate structure can deliver pieces to whatever's needed within a certain region.
Can you explain, because a lot of people I'm sure aren't really aware of what some of those services that an MSO might provide to a provider? What are some of the services that they might find within an MSO?
Yeah, a lot of it's trying to get the risk off of the provider. As an attorney, I always like to look at what the heck risk is, what are the forms of risk and what are the national trends. But a lot of it's trying to unload that risk. So there'll be things like there's pre-made forms, and there's ways to teach you on how to play nice in a sandbox. It decreases your financial and your tax risk. But other things that are delivered by the clinically integrated network and an MSO are things like a common, communication. So common communication is anything from the language that we use. Remember that CA anecdote I gave you? So you're agreeing on a common language amongst the group. You're agreeing on a common treatment pathway, what to do and when to do it. You derive that from evidence and you disseminate that to your provider members. So that's delivered. You deliver through an MSO and a CIN practice management. So that has to do with data collection. It has to do with the proofs of what you're doing. Is that working? Is what you do, impactful for the area that you're servicing or the contract that you're servicing? So there's that delivery. Then there's the delivery of cooperation, collaboration amongst providers. And there's also, scheduling, deliverance, and which patient to see which provider at what time in that time frame. And I think that's about it.
I muted myself. And billing is a component oftentimes, or not typically?
Yeah, it is, because that's where a lot of your data comes from.
Oh, okay.
And and when you're trying to diminish that, burden on a provider, the billing and practice management, the revenue control management it's all very important.
Okay, but you're still operating as an independent practitioner, correct?
Absolutely. Yeah, you still go out there and you practice, which that has great value too, because what it does, it allows you to still be impactful in that retail pain management, which is kind of another name for how do I deliver the best service to my cash patients, you know?
Mm.
And that's
Okay.
important for the system at large. We want people to have access to, you know, effective value-based retail pain management and lifestyle management. And that's also held up well in these MSOs.
Okay. Interesting. Interesting. Let's talk a little bit about risk, since it's come up multiple times so far. Um, you know, what are a couple of the types of risk, and what can the average that we're a field clinician is exposed to? And then a couple comments about what the average clinician can do to mitigate some of those risks.
Yeah, thanks, John. And risk is a big one. You know, coming from an attorney, again, looking at this stuff through my time in practice. I also sit on a board of an ACO. That's a Greater Macomb Physician Network, and we have literally hundreds of family docs that we manage. And I'm also on the advisory board of a national malpractice insurance company. So I get this risk from people in a lot of different formats, you know, but you can kind of distill them down. You know, I would challenge our audience right now to just put in chat what you think is your biggest risk at the office, and just see what spontaneously comes up. We may see things like, oh, I'm afraid of malpractice, of getting sued, you know, and that's really an obvious one, right?
Yeah.
But, you know, one of the hardest things to keep from getting injured in your practice, in other words, the easiest thing to damage, but the hardest to repair is your reputation. And there's risk when you go out on that limb for that fruit. You know, when you're working with somebody, your reputation can get shot in just one bad referral, or it can happen over a long period of time if you're sending people to low value providers. And you know, there's this thing called attribution that happens with ACOs and PCPs. If they send a patient to Tom Neuner, and Tom Neuner sends the patient to PM&R in my own office, and PM&R is doing something that hurts the PCP who sent them in the first place, because behind the scenes, Blue Cross is attributing the behavior of low value provider to that PCP. Now the PCP doesn't make as much. They get the report back. What happens to Tom Neuner's reputation? And I know it's a lot to say in one sentence, but attribution, character, and reputation is really important. You have to keep thinking of, in terms of, like, you know, birds of a feather flock together. That's how you're viewed from some of these other, not only patients, but insurance companies, employers, attorneys. You know, they see who you hang with, what you're doing, and they'll attribute to your character and reputation what's going on with those other birds of a feather, right? So that's a risk. Taxation's a risk. So you have to be mindful of your corporate structure when it comes to risk management. And you have to watch out for your credentialing and your financial risks. You can actually lose your credentialing with an insurance company by referring to wrong providers or doing the right or wrong thing, rather. And I know people are aware of that, but watch how and who you're credentialing with. I remember times credentialing with a certain insurance company, and then other insurance companies would say, hey, no, you can't have this price with insurance company A. We want that lesser price also. And all of a sudden I'm getting, you know, paid thousands less per year. So that's a risk, right? And don't forget other forms of risk, like people hurting themselves in your office, you know, getting on the wrong equipment at the right time, sticking your fingers in things, you know, little kids falling. That's all risk. Sexual harassment, you know, and ignorance of what's trending out there, I think, is a big risk. So what I mean by that is the trend right now is this value-based healthcare coming at us, and value-based healthcare reimbursement is a trend. Grouping of all the providers, as far as we know them, are grouping together. Why am I still practicing by myself? That's a trend. And if you're ignorant of these trends, you're at risk. And again, you know, if I can continue just to talk about some of the national trends regarding risks,
Sure, sure.
um, we're seeing a big focus with lawsuits against providers almost solely based on documentation and data.
Oh, oh,
So if, and everybody here is just sick of hearing about documentation, but gosh dang it, get out there and learn it and make sure it's happening. I would bet, probably everybody on this call, if you're looking at Spine Care Partners and PSPN, you're pretty dang good at documentation, but make sure it's top drawer. And watch out for vicarious liability. Again, that's one of my favorite words because that's big. And if what that means is if I send my patient to that PM&R and that PM&R turns out to be, a child molester, I am vicariously liable. That's the trend nationally against us. If I send somebody to, John Ventura and he treats that patient so wonderful and everything's happening great, I get the other side of the coin, the halo effect. It's kind of like I'm vicariously lifted, right? So just be mindful of that vicarious liability of what the other person's doing. Make sure you vet them before you send them over, that you know what their past is like. How do they behave based on a national standard of PM&R, so on and so forth. And your own vicarious liability. TCPs are looking at you, John, if they're going to be vicariously liable for sending somebody to you. So those are national trends. Predictive analytics are national trends. They're what they're doing is they're looking at how you practice, the codes you bill, and then you put that into a nice little computer assisted program, and you can get a predictive analytic on how much risk you are to a system like an ACO or a hospital or your malpractice carrier or the patient. So predictive analytics are coming on strong. One that's really interesting to me is this whole notion of social credit scores and all of the multiple permutations that entails. Like, a social credit score might be like, oh, Tom got a speeding ticket, goes on your social credit score, right? Not good. Or Tom is overweight, so Tom's going to pay more for insurance. Not good. Well, in the professional realm, social credit scores can be the data that's being gathered on you right now, your impact on a patient within that patient's whole journey throughout a healthcare system is being tracked. They're not doing anything with it yet, but it's being tracked, and they're starting, the proverbial, they are starting to say, you know what, for a patient with this type of problems, we're going to send them over to Joe Smith instead of Tom Neuner, because Joe Smith has proven that he has a much better record with this type of disease state. So it's kind of like a social credit score on that patient base, if you will. It'll outlie or it'll underline the high performance providers, but the flip side is it's going to marginalize the lower value providers, and those are called outliers. So the national trend of risk for all of us is try not to be an outlier. There's risk there. There's financial risk for you. One risk that we on the malpractice side and premises liability side that I think goes under the radar is patient satisfaction. So if a patient is not happy with their billing or their finances, or they've had surprise billing, or they got in a fight with some staff member or crabby, front desk guy or something, or their outcome isn't exactly what they wanted, or they felt like they paid too much for the outcome, that's all patient satisfaction. That's going to ramp up your risk exposure with them. Watch out for consent forms. You have to fill those consent forms out, and that's actually a moving target, right? Consent just doesn't happen once. And in 1990, when you first saw this patient, it never happens again. It's actually happens almost on a daily basis. You have to get consent and document that in your notes.
sorry, I'm muting myself again. Do you think it's sufficient? And we won't hold you to this. Tom Neuner told me I should do this. Is it sufficient to get verbal consent and document that in your note that you did versus having an actual document that they sign?
Yeah, I think it's in addition to, John,
Yeah. Okay.
one technology coming along is ambient noise technology, where EHRs will actually be recording ambient noise in your treatment room,
You
which is
mean
really
like
cool.
Alexa?
Yeah, even Alexa on steroids, so it'll pull out things like, did John get consent? Did John tell the patient smoking cessation?
Oh
So
my goodness.
really, yeah, really cool stuff. But let's say even on paper, if you're still doing paper charting, consent's a moving target. Just get it all the time. Okay, we're going to take you over here, and we're going to perform some decompression here. You have to get that consent, and especially
Okay.
if you're at the end of a treatment cycle,
Hmm.
if an episode has resolved, if somebody has gotten worse and you're changing your MO, get consent.
Okay, that's great.
Yep.
I want to change direction a little bit just to ask this question because I'm guessing, and then we'll open it up and let people ask you some questions. Um, from a corporate standpoint, do you have any, and this may be more accounting than legal, but do you have any recommendations what a field practitioner does if they're a solo practitioner? Should they just remain solo practitioner operating under an employee ID number or a social security number, or should they form an LLC, an LL, or an S corp, or any recommendations on what would be the best legal entity to practice under if you're a solo practitioner versus if you're two or more? Or is it just individual?
Yeah, it's going to be individual and state-based, but chances are it's either going to be an LLC or some states are still using DBA, some are using professional corporations. But as dumb as it sounds, you guys, people beat this to death, but talk to first the tax man and then talk to the attorney,
Okay.
because they're going to squeeze out of you all of those things that we just cannot squeeze out on this call. All of those individual needs, wants, directions, and where you're headed, and they'll give you the best vehicle to go forward.
Okay, that makes sense. Please, if anyone would like to ask a question, you can either type it in the chat or just raise your hand, and David will unmute you so you can, so that you can ask Tom this question. Another thing I wanted to ask you about, Tom. And it has to do with promoting your practice, say to PCPs.
Oh God, yeah.
Or the business side of your practice.
No, I love that.
Yeah, and what advice would you give to a field clinician in terms of that would be within the realm of not putting you at risk, not exposing you? What would be some good ways to get yourself out in front of these other groups without putting yourself too much at risk?
Well, John, I was really excited until you said not put yourself at risk, because again, I just want to give you a gentle amendment.
The fruit's out on the limb.
The fruit is out on the limb. So put yourself at a calculated risk, right?
Yeah.
So here's this whole thing about, I like to call murmuration and evidence. When you see a flock of birds, a flock of sparrows, and they all act as one out there, that's called murmuration. Or think of a school of fish, murmuration. And so it is with clinicians. If you're behaving based on evidence, like the vast amount of clinicians do in that spine space, that's murmuration. Now, murmuration gives you protection. So when you go out there and put yourself out into them, first of all, make sure you're murmurating with what is known to be something that is worthwhile and factual and evidence-based. I think that's the single biggest thing. And that doesn't fly in the face of innovation, because innovators tend to be outliers, right? You can still be an innovator as long as you're basing what you do on evidence. So that's number one. The second thing to talk about when it comes to putting your practice out there right now, regardless of how you want to group your practice, One of the biggest things you can do that's both factual, it's needed, it handles consent, and it handles reporting, it handles insurance issues, is make sure that you're sending your note to the PCP. I mean, when I first started practice, for crying out loud, they were called like a first surgeon's report or something bizarre. Now they just simply call it first visit note or evaluation and management note. So what I saw one group of clinicians do out east is they would take the patient's report of findings. They'd read it to the patient. They'd have the patient sign it, and then that was sent to the PCP. And here's what happens: first, you've done your report of findings. Second, you've had the patient sign it, so that's your consent. Third, when that goes to a PCP, every PCP on the planet has EHR, and that note is scanned into the EHR. The EHR then has your name on file. I mean, it has to be scanned in there, right? And we hope if is correct, if the PCP sees your behavior as fitting their needs, yeah, you're going to get more referrals. So send that consent, send that PCP note, and you can probably get one from PSPN if you don't have one. These clinicians, they have to be aware of these referral loops. Choose high value systems of who you refer to, and be mindful of the groups that are in your area. Chances are it's going to be an ACO. Go there, find out what the heck is their problem. What do they need? What do they want? I mean, we can tell you, nationally, PCP needs they need time, they need more money. They're trying to get rid of burden. They're worried about leakage. They're worried about compliance of their patient. They're worried about venue shopping from people, going elsewhere. So address that with the PCP. Say, look, I can help you with this money, time, burden, leakage, so on and so forth. And also be mindful of the ACO problems. When I sit at this ACO, I look at their metrics on how we measure a PCP's practice behavior. And it's fascinating because the metrics have to do with HEDIS. And the metrics have to do with how a clinician is behaving when they treat cardiology or, any other comorbidity that you may be seeing in your office. It's not only back pain, it's diabetes, it's vaccinations. Yes, the bugaboo vaccination. It's pharyngitis for minors. And what I'm telling you is that as a chiropractor, when you go to an ACO and get a meeting with that ACO administrator, tell them, look, I can help you with your metrics, all of them. And why do I say all, not just lower back, which is one of their most important metrics? I say all because you are an influencer of that patient. You can also tell the patient, go get your smoking cessation, go get your exercise, get out and move. And so the PCP at that ACO gets paid more. We talked about attribution, right? Gets paid more if you behave properly. You're going to get more patients out of it. You're going to get more referrals. You'll get a higher standing, and it opens doors for you across the board. So that's what you can do now.
Yeah, that's great. That's a really, really good point. I want to be respectful of everybody's time. This was from 12:15 to 1 p.m. So if anybody does want to throw any final questions out there, please feel free. But I want to thank you so much, Tom. Yeah, any one of these topics we could probably keep going on for another hour, because they get so involved in there's so many individualized issues that can arise relative to them. Let me ask you this final question. And because I know you sit on a board of a malpractice company, is there evidence that you're aware of that use of an electronic health record system improves or reduces risk or reduces, I know the OIG did the Office of Inspector General did a review of chiropractic record keeping some years ago. I haven't looked at anything recent, and this was quite a few years ago, and found that, by and large, documentation in the chiropractic profession was abysmal. So do you know of any evidence that use of an electronic health record actually reduces risk?
Yeah, that's another good question. In some areas, John, it increased your risk. In some areas, it brought it down. And you know why? Some of the programs, and I'm going to say not the top 5 programs, but some of the programs that we as chiros used,
Yeah.
the language in what was computer generated, and they literally in court held up the language in it from patient A to patient B. It looked exactly
It
the
was
same.
the same.
So yeah, but now I think the trend is you definitely want EHR. It'll bail you out, so many ways. You have to get the right EHR, and what they are is not for me to say. It's probably going to be your top 5 most common ones and you want one too that's used by your ACO, used by your, if at all possible, get one that your area clinicians are using, because you pop up on the radar much better.
Okay. I mean, they must be starting to incorporate things like ChatGPT into these notes so that every note doesn't look exactly the same. I don't know. Okay.
Right.
That was one of the things I found. Yeah, having back when I was in practice with electronic health records and if you weren't careful, your notes tended to look the same.
Right.
Yeah.
Yeah. David has a question in chat about malpractice case examples. David, probably the easiest one to do is to go to your malpractice carrier. They've got them by the bunches, and you can read those, the synopsis of them. They definitely get very interesting. And again, they're going to go back to those things we talked about. They really are. Patient was unsatisfied. There was no consent. I was touched in an inappropriate fashion. I fell walking in. I got on the table, broke a rib. Really, that's those big ones.
Yeah. Okay.
Mm-hmm.
All right. Tom, thank you so very, very much. I want to thank everybody for joining us today. This is recorded, and we will post it on the Primary Spine Provider Network website, where you'll have access to this and all the previously recorded webinars. And we look forward to seeing you again next month for our next webinar. Thanks again.
No
Tom.
questions, John?
No, I didn't see any in the chat or hand raises.
The only other time I got no questions when I was speaking in front of a large group was in 1981. I spoke in front of 350 people, and all I had to say was, "I do." No questions.
No, nobody asked any questions.
Right.
No
all right. Thanks,
dissension from the audience. Thank you so much, Tom. Thank you, everybody, for joining us, and we'll see you next month. Thanks again.
Bye now.
Bye now.